Good afternoon, everyone. We're just going to give a couple of moments for people to start joining the webinar, so we'll get started in just a moment. All right. Good afternoon, everyone. This is Stephanie Winters from the Vermont Medical Society. I'm wearing that hat today. Some of you may know me with other hats on, but that is the role I'm playing today. And I'm really excited to welcome you to the first series in our webinar series on refugee health. Today, we'll be talking about cultural considerations, and we're able to do this really thanks to Tracy and a grant through the Refugee office for the state of Vermont. So we're really excited to be able to offer this. And so I'll just run through a couple of slides just so that everyone knows our disclosures. We are offering continuing medical education and social work credit for this webinar series. So this is our disclaimer. This will qualify for 3/4 of an hour of CME, and you need to claim that CME within 30 days. And Birdie Polly, who's on with us, will be sending emails out to our attendees telling you how to claim those credits. This is just a disclosure slide that we have to show you, saying there are no disclosures and we did not take any kind of support from any industry. And then this is just our Refugee Health website. We are holding a whole series, so these are the dates we have set up. The website is at the top, and please visit this often so it will be updated with new dates. We have a couple that are yet to be determined, and it has all of the places you can register for each date. And it also includes a lot of refugee health resources, key medical resources, and links to be able to get there and get more information. So with that, I'm actually going to introduce our two speakers. So I'm really excited for our first two speakers to kick us off. So we have Tracy Dolan, who is the director of the State Refugee Office since 2021. And previously, she served as the Deputy Commissioner of Health. And we have Andrea Green, who's a pediatrician and director of the New American Clinic at the University of Vermont Medical Center. So I'm going to hand it off to Andrea and Tracy to start the presentation. Thank you.
Thank you very much, Stephanie. It's great to be here, and I appreciate the Vermont Medical Society being willing and putting the effort into developing this series. Hopefully folks will be able to pass information on to their colleagues so that people can go back to your website and see it if they're not able to view it today. So today, myself and Dr. Green will be talking about specific cultural considerations around providing healthcare to Afghan refugees. Please move forward, thanks. So the mission of refugee resettlement in Vermont is to promote and provide a safe and welcoming home for refugees and immigrants, and to promote their full participation as self-sufficient individuals and families in the economic, social, and civic life of Vermont. So my office is part of the state of Vermont, and it sits within the Agency of Human Services. Next slide. So how many refugees do get settled? Here we find worldwide, there are 26 million refugees settled worldwide. Less than 1% of them are resettled permanently in any new country in a given year. So most refugees remain, on average, refugees for 5 years or more before they're resettled in a new country, and some remain that way for decades. People often wonder, why don't countries nearby help those who need refuge? And in fact, many refugees are resettled in places where their economic systems are already quite stressed. Some of the countries that hold the world's highest numbers of refugees are Turkey, Sudan, Colombia, Germany, Pakistan, Uganda. And right now, of course, countries neighboring Ukraine. So the United States is certainly generous in that we take in refugees, but we are not one of the major players when you look at refugees worldwide. Um, every year, the president issues a presidential determination on refugee admissions. So basically sets a number. In October 8th, 2021, Biden set that number for 125,000. Then, of course, we had the Afghan situation, which really did affect the ability to bring in people. And so that number was less for 2022. Probably that number is closer to 65 or 70,000. Not refugees per se. Many of those were parolees coming from Afghanistan, but certainly their experience is the same as a refugee would be once they're here. Those numbers were quite a bit lower in the years prior to 2022. During the Trump administration, there was a marked effort to reduce refugee resettlement into the US. And so you saw that our numbers went down significantly. Here in Vermont, we were receiving about 350 a year between 2008 and 2016. And then after 2016, those numbers dropped quickly down to a low of about 23 refugees in 2021, in part due to COVID as well. But now we're back up to about 290 in 2022. So some of those numbers just need to be adjusted a little bit. When I say 290, again, I'm using the word refugee fairly broadly there. Most of those were actually humanitarian parolees, and those were the Afghan arrivals. But we had about 30 additional refugees so far in this federal fiscal year. Next slide. So Vermont refugee resettlement, generally how it works. I think I mentioned this a little bit earlier, but the number of refugees assigned to a state is determined by the State Department. So while we certainly have input and the refugee resettlement agencies have significant input, ultimately that number is determined by the State Department. Vermont has two resettlement agencies, USCRI and ECDC. USCRI operates in Chittenden County and also has a sub-office in Rutland. And ECDC is new. They started last year. They have their main office in Brattleboro, and they also have an operation in Bennington. Again, mentioning here that many of our newcomers this year were Afghans, and so I am including them broadly as we speak about refugees. However, their status was primarily humanitarian parolee. When they got here, they were eligible for the same services as other refugees due to a congressional act, but their immigration status is different. So there's a level of stress now as they are quickly trying to apply for asylum so that they can stay here long-term and move through the process. And how is the work funded? It's funded in a variety of ways, through the State Department, through the Department of Health and Human Services at the federal level. Some of the funding comes in directly to resettlement agencies or to service agencies. Some of it comes through this office, the State Refugee Office, and some of it comes in through foundations or other parts of state or federal government. All right, next slide. And then we'll move past this one to the next one. Thank you. And so we have about, as I mentioned, about 290 refugees in total, about 260 Afghans and 30 others. Just really briefly, and in future webinars, we'll go over this, but the resettlement agencies are largely responsible for some of the core services. They're responsible for meeting them at the airport, helping them get their first home or getting them into an apartment, helping them land a job. One of the goals when people get here is to start working very quickly so that they can actually pay for their services. They sign them up for benefits. Most of the refugees will be eligible for the same kind of benefits other Vermonters would be eligible for due to having a low income, so they can, the resettlement agencies sign them up for that. They're also responsible for linking them to English language learning and other services that they will need. And finally, in terms of the health aspect, they are responsible for helping them get their first medical appointments for their domestic health assessment, which is the assessment that refugees receive when they arrive. Ideally, they get that in the first 30 days, but sometimes that might take 90 days or even more, depending on whether or not we can get folks in. And this is a rather extensive medical screening and assessment. And we'll go to the next slide. So just a little bit more about the kinds of benefits that folks get. They get some welcome money when they arrive. It's a pretty small amount, $1,225. And that's really meant to help them in the first few months, set up, basic needs. It might help with a security deposit. It might help with something else that's really needed. And again, they can get Reach Up, which is our Vermont's TANF program, in the same way that other families can get it. If they can't get Reach Up because they're a single, there is a special federal program for single adults, and that's Refugee Cash Assistance, and they can get that for up to 12 months. So a few updates since this slide. So it used to be 8 months, and now they can get that for up to 12 months. Medicaid, they are mostly or almost all eligible for Medicaid. And so that's something that the resettlement agency will do. We'll quickly sign them up for Medicaid. And they're also eligible for WIC, Three Squares Vermont, and for childcare assistance. Next slide. And trauma and the refugee experience. As you can imagine, arriving in a new country, all kinds of challenges with adjustment. Language is a big one. With our Afghan population, we've found that while a lot of us expected that a lot of them would speak English because they had been working with our American military and other partners back in Afghanistan, it turns out that most of them do not speak English or do not speak it proficiently. And so we are finding a lot of folks who need English language lessons. And so that's always difficult coming in and not knowing the language. And of course, literacy is an issue too. I'll touch on that later, but Afghanistan has a very low literacy rate. So even for those who do speak, they may not be able to read their own language or other languages. Transportation, it's a big issue for any refugee or newcomer coming in through that kind of mechanism. It is expensive to get a vehicle. Vermont is relatively rural, doesn't have great public transportation systems. So that's something we really think about when we're thinking about where people are going to live or what kind of job they're going to get and where that job is. Isolation, because Vermont is relatively small, our refugee population is relatively small. A lot of folks, when they do come into the US as refugees, they generally can choose where they want to go. And if they have family or connections, they will tend to go to a larger state or a place with a larger population of their nationals. In the case of the Afghans, a lot of those places filled up pretty quickly. Sacramento, for example, and some of the other larger cities. And so for those who were not able to get there, or for those who chose for other reasons, they did come to Vermont, but they don't have much of a community here. And so the isolation is a big deal. And so what we're trying to do is make sure we have a lot of opportunities for people to spend time with each other. They obviously have been very welcomed by Vermonters, which is great. But it's really that connecting to other refugees that's also very important. And then the cultural acclimation. We know culturally, most people arriving here from other countries in this situation will see a pretty big culture shift. And so that always takes time. They do get a little cultural orientation when they come, but the acclimation really occurs over months and years. And then the history of trauma. Most refugees will have some kind of history of trauma. Refugees leave their countries not because they want to, but because they have to, often due to persecution because of political or religious reasons. And so the history of trauma is significant for our Afghans. It happened very quickly. They were not in another country as refugees for years. They were really plucked from their homes in a pretty rapid traumatic style. I'm sure a lot of you saw on television planes taking off, and tragically, some people even hanging on to planes as they were taking off, and the chaos at the airport. We have families that have been ripped apart. We have families here. I met with a family last week. They have some kids here. They have two teenagers back at home still, staying with a relative. Some came here and have brothers and sisters home, have many children at home. Not all were able to get onto the plane. And so that level of trauma is high. And then, of course, if they were targeted by the Taliban, which many were, or if their family members continue to be targeted, just the fear of the harm that could come to their family members or that already has come. So a lot of difficulty there and a real need to figure out how to assist. Some of that is around mental health counseling. Some of that is around making sure we provide a lot of opportunity for people to connect with each other. Next slide. So a few cultural notes, and I want to give a preface here that when I talk about cultural notes on Afghanistan or any country, these are general. You may meet people and say, none of this applies. But for the most part, these are some generalizations that could be helpful. The official languages are Dari and Pashto. English is not routinely spoken or read by Afghans, so many people do require an interpreter. Literacy levels vary greatly. Males are more literate than females, but those rates are low, 55% and 30% respectively. And education levels vary. We have some folks coming over who are engineers or lawyers. We have some folks coming over who have not worked before or who have worked in manual labor types of positions. Next slide. Greetings are very important in the Afghan culture. An Afghan person might place their right hand over their heart and nod in greeting. People of the same gender may also shake hands with the right hand. People don't usually touch people of the opposite gender during greetings, unless that person is a close family member. So if you're a man and you meet a woman, you should wait to see if she extends her hand, or you can always just place your hand over and greet and nod. For the sake of modesty, men and women keep eye contact to a minimum as they greet one another. And extensive introductions and greetings are the norm. Our Western style is to say hi or get right to business. And in a lot of other cultures, including the Afghan culture, that might be seen as abrupt and rude. And you might need a few silent pauses to let people say hello or to check in about family or to greet in that way. Next slide. A few other cultural notes. Gender. Men and women have very defined roles in Afghan culture. They are usually separated from one another in public spaces. Men and women only interact in families or in tight-knit communities. We are finding that with the Afghans here, although of course there are some exceptions. Domestic violence in the marriage is common and widely accepted. A significant difference from our country in terms of acceptance. When possible, Afghans should be seen by physicians of the same gender as the patient. That is a challenge in Vermont or in a smaller community, and it's something we're working hard to try to make happen. Women are generally not free to make their own decisions. Men usually make the major decisions for all the female members of the family. In a group of Afghan men and women, you would expect that the men will talk to each other without the women engaging in conversation beyond introductions. Of course, you may see exceptions to all of this, possibly particularly among younger people. And it's a good idea to leave the door open during one-on-one meetings with an Afghan person of the opposite gender in order to respect their culture and their comfort level. Next slide. Beliefs about illness. Women may be hesitant to present their symptoms to medical personnel. We have had the case, not just with women, with some men too, but particularly with women, where they are very hesitant to be sharing some of their symptoms, very concerned about the diagnostic tests, hesitant to know and then to follow up on some chronic and serious illnesses. And so that will possibly feel very different as a provider, that you may have someone very hesitant to know, or you may have experienced that with other cultures or even Americans. Most women, particularly those who are rural and non-literate, don't make decisions upon themselves. So you will have to think through who to connect with to provide medical advice when you're speaking particularly with the women. Some people believe illness is God's way of testing individuals and family. They might believe that recovery requires prayers, fasting, or gifts to charity. And Dr. Green will talk to you later about how do you dial into those beliefs and help partner in a way that makes sense for your patient. When caring for Afghan patients of either sex, keeping their bodies covered as much as possible is ideal. Bodily exposure may be embarrassing or shameful. And finally, Afghans may also believe in natural causes of illness, including dirt or wind or cold weather. Traditional Afghan medicine involves humoral imbalances such as hot and cold. Next slide. And finally, I'm going to hand over to Dr. Green. Again, I want to note that what I've talked about are some generalities. You may find differences in your own experience, but some good things to keep in mind. What I didn't highlight here is that Islam is the significant chief religion of Afghans, so most will likely be Muslim. And so thinking about that and how that plays into almost every aspect of their lives will be helpful as you're providing care as well. Thank you. Handing off to Dr. Green.
Thank you so much. So I think you guys can hear me. So I'm going to take some of what Tracy has taught us and we're going to use a framework that I like to use. I find it extremely helpful, called the patient-centered approach. And this is really a framework that allows us to consider culture in healthcare. I'm going to lay over this some of the cultural pieces that Tracy has taught us, and I'll mention a few more. But this is really a nice context for any interaction with anyone or any group of people you're starting to spend time with. And again, this has a lot of generalizations, and as we know, every individual is unique and different, but this is a way that we can explore both a group or an individual to maybe understand how to provide quality healthcare and understanding those cultural differences that may exist. So this framework was developed by Crilio, Green, and Bentecourt. And as I told you already, it's called the patient-centered approach. It has 4 key components, and we're going to go through these with some examples in the rest of this lecture. So the first is assessing the core cross-cultural issues, of which there are 5. The first being communication style, the second, understanding if there's mistrust or prejudice, the third being family dynamics, which Tracy's talked to us a lot about, the fourth being spirituality, customs, and traditions, the fifth being sexual and gender issues. And again, we've touched on some of these, and we'll just give a few more examples. The second key component is exploring the meaning of illness. And again, Tracy talked to us a little bit about this. The third is determining the social context. And the fourth is engaging in negotiation. And so I will not come back to these to review, but you'll have all of these slides afterwards, and hopefully this will be really helpful and you can refer to it and refer to the citation if you'd like to learn a little bit more. Great. So let's talk a little bit about communication style and building trust. And I'm going to do this sort of giving examples of as you would be meeting people or walking through encounters in a medical encounter. So for those of you who are not practicing medicine per se, I think a lot of what I will talk about is a medical encounter, but it applies equally if you're working with somebody in a social work context or in a psychology context or in any other context. So when you're learning about a new group of people, sometimes to learn those generalizations, it can be helpful to look at what's called cultural backgrounders. I've listed one source here, and when you look on the website, you will find some of those sources. And these are a way for you to get even more than we're talking about here, understanding with more depth and more breadth, traditions, customs, and language, history, politics, geography of a certain group of people so that you can really have a great understanding. And with that, that can give you information that allows you to build trust, ask questions. Communication is really important. So you want to make sure that you're using an interpreter throughout any visit of any type. We are very lucky in Vermont, at least from a medical standpoint, we do get refunded through billing for our use of medical interpreters, so there is no excuse not to. And it's important to know that interpreters are not just there to be a conduit for information. They can step in and be actual cultural brokers. So they're wonderful people to give you sometimes some context or to ask to step out of their role as an interpreter, to just ask for some clarifications if there's some misunderstanding that they're experiencing. Also, just really important to understand that we may have a word that's very brief that we use to describe a concept, but that word may not exist in another language. And so it may take longer to present that idea. So it's not going to be an equal amount of time for both languages to be able to talk about the same thing. When you welcome, as Tracy has already alluded to, it's really wonderful to welcome people in their own language and to learn some of the greetings in someone's language. So assalamu alaikum or salam is a pretty good greeting for whether or not someone speaks Pashto or Dari, the 2 main languages spoken. It's really helpful when you're working with people who practice Islam to say mashallah after any compliment or praise. And this is just an acknowledgement that is a gift of God for someone to have this, whatever it is that you've complimented or praised them about, and families really appreciate if you use that term. If you use it incorrectly, often they will correct you and just chuckle about the fact that you tried. And so it's a lovely way to build trust in that you're saying that I would like to meet you and understand you and your culture. And I acknowledge you as a person coming from a different place and a different culture. In order to build that trust, that very first visit or any visit where it's appropriate, it's really, really important to describe consent, confidentiality, the limits of confidentiality, and explain a little bit about how our whole medical system works. and also to build that trust and communication for people who do read or write. And it's always helpful to say, what language do you speak well in? And do you prefer to have everything offered orally? So you may give video materials or have written materials, but to try and have them in someone else's language is another great way to build communication and trust. We talked a little bit about family, and you heard from Tracy already the importance of understanding who is in the room. And so when you first have that first visit with any family, make sure that you have a lot of time. Spend a good part of that visit just getting to know each other. So doing your greetings, explaining the systems, getting to know each other, asking all of that lovely small talk that allows us to really build relationship. And in asking, you want to know about who's in the room, what role do you have in the family, and who's not in the room, who didn't get to come. Is there a second family? So people who practice Islam can have up to 4 wives. And so there may be 4 families, but what we found a lot is that there is a second family, and that second family may or may not have come to United States with the one father who has these 2 families. And so there may be people left behind. There may be children in that rush to get out who were not able to be here. And so it's really helpful to know who's in the room and who's not in the room. Also helpful to know that if you have any records, you may find that there's lots of different spellings, or you may find that everybody seems to have the same birthday. So important to know that often people who are born overseas don't have a birth date per se. Not everybody is born in a hospital with a calendar and somebody recording it. So you may have inaccuracy of ages. Lovely to try and figure that out if you can. And you may have some differences in spelling of names. And so this again is a great way to talk a little bit about that, because vowels and how names are spelled can be very different. And if people don't have a particular way that they write a name, or they're illiterate, they may there may have been some confusion in writing that down. Gender has already been talked a little bit about, but that is again another of our cross-cultural considerations. We've talked about modesty, we've talked about being a patriarchal system, and I do like to talk about how some of those generalizations can be broken down. We do find that when we are in medical encounters, we are really trying with our Afghan population to have female physicians with female patients and female interpreters, and that is definitely something that's requested. We protect people's modesty at all times. I do undress people fully for their medical exam at their domestic health assessment. And we'll go through the domestic health assessment in a different webinar on July 28th for people to learn more about that. But keeping people covered and having any males out of the room is how we do that. But what I have found is often the second visit with families, the husband has already met me, and I'm a pediatrician, so I'm working with the family unit, and I find that the husband definitely defers to his wife, and the wife and I have a lot more direct conversations with the interpreter as he's gotten to know me and we've created relationship. I've also learned through those interactions that men are often very affectionate with their children, and wives have told me that they do a lot of the cooking. So some of these maybe stereotypes we have about different roles, it's been lovely to have them be changed by getting to know families and learning more from those families. So again, in building trust, I think it's really important to build expectations around our medical system and to have a sense of what people may have experienced in medical systems overseas. So for our Afghan families, for example, people will often have incomplete immunizations. They will not, in their hurry to get out of that country, have brought any paperwork with them or any immunization records. So we do have conversations about the fact that they may have had their children receive immunizations overseas, but because we don't have that in paper, we're having to redo those immunizations, and it's not a problem to get them a second time. But having a conversation and acknowledging the fact that many families did seek healthcare for immunizations for their children, acknowledge that that healthcare existed, has been really wonderful for building trust. We talk about preventative healthcare, and we talk about the fact that that is not something that is done overseas, but that's something that's really important in our healthcare system. And so that we do want to see you even when you're not sick, because we want to talk about staying healthy and how to stay healthy. And so if there is a follow-up that needs to happen, it's really helpful to talk about why that follow-up is important, what we're going to be discussing. So it's not that, oh, I'm feeling better, I don't need to come. Also to talk about canceling appointments, finding out ways to call to cancel, which isn't always easy, but letting people know about the expectation so that that doesn't make people have any resentment about not coming. We've had a conversation to set up why it's important to have that communication. Important to know that a lot of people in Afghanistan could purchase antibiotics or other medications over the counter that require prescriptions in the United States. And so there can be an expectation that antibiotics or something will be given at every visit. This is not solely true for the Afghan population. This is true for a lot of populations that come from overseas systems into our medical system. And so wonderful to acknowledge that and just say, this is a viral illness. Here in this country, we don't give antibiotics for viral illnesses. Here are some homeopathic treatments that you can do. This is why we don't. Acknowledge that difference so that people feel that you are not giving substandard healthcare by not giving a medication, and just really clarifying that. In addition, a lot of people need dental care when they're arriving, and it's been a little bit frustrating because we don't have the medical system and the dental system kind of working in conjunction together. So we have to link to outside dental homes. And again, this is something where we can provide some understanding of how our healthcare system works and the fact that we're going to refer you to a dental home. It doesn't happen within the medical home. So the second part we talked about is the meaning of illness. So that's just a little bit of an overview, very brief, and I know not enough about some core cross-cultural issues that that are important to consider. And so now we'll talk a little bit about meaning of illness. And Tracy's already touched on this. She talked a little bit about how illnesses in general in Afghanistan are believed to fall into three categories. The first being evil eye or evil spirits. The second being sort of an imbalance of fluids or an excess of heat or cold in the body. And the third is contagious and therefore unavoidable illness. These are very common ways that people categorize illness in many, many different countries. And so we'll talk in some examples a little bit about some of the ways people manage these. But we'll talk a little bit about evil eye and some protections for evil eye. But I want to talk a little bit about hot and cold. And I think this is an important thing to think about. We in general have treated water systems here. So we don't tend to think you need to have hot foods or hot boiled water, warm things when we're sick. We will allow kids, for example, to get a Pedialyte popsicle when they have dehydration. But for a lot of people, that is not something that they would use as a treatment because they need to boil water and for that water to be safe. So we tend to not think hot and cold are the same way, but a lot of people you're going to hear about, the cold weather has caused the problem. This is what the issue is. And we tend to think if you dress warmly, it's not an issue to go out in the cold. We tend to think that you can drink cold things when you're sick and it's not a problem. Prayer is used for lots of people as a way to manage illness, as well as traditional or herbal medicines or dietary restrictions. So these are all really great things to ask about when you're working with patients, so you can understand some of their traditional healing. And in addition, to understand illness from the perspective of the patient and the meaning of illness, you can use something called Kleinman's 8 questions. So these are a series of questions that help you to understand the problem from the patient's point of view. So the first question is to just ask someone what you call this problem. There may be a term that they are using, and this term will help you to then understand more about it. Maybe this is an illness that has a whole complicated understanding and it's brand new for us. So this will help us to understand it. Then we can understand why they think the problem occurred. Was it a hot and cold issue? Was it the wind? Was it dust? Was it something else? Why do you think it started when it did? How serious is it? How does it work? How long will it last? What treatments do they think they should receive? What's the main issue that this problem has caused for them, and what are they most afraid about? So these are Kleinman's questions, and they're very helpful for understanding things from the patient's point of view. Social context is also really important, and I wanted to use emotional health care as the way to talk a little bit about social context. Tracy has already explained a little bit about high level of exposure to trauma in our patients. I think it is not surprising for people coming from Afghanistan that they've had a lot of trauma. We've seen this also for our soldiers who've been there for a brief time. So they may have had a 1-year deployment and have a lot of trauma as a result. And these are people who've been living in this trauma for a long time. So there is the trauma of the chronic war and violence for kidnappings, bombings, different things that they've been exposed to. As Tracy mentioned, there's the trauma of evacuation. And as she mentioned, there's also the trauma of the resettlement, the loss of the familiar here, as well as the family that are still experiencing trauma in Afghanistan. So it's really important that we ask about emotions and stress that people are experiencing. And it's not actually recommended that we ask directly about specific traumas. And that's because unless we have those resources to support people right in place, it can be really re-traumatizing for us to ask direct questions. But if we're asking, it can be quite taboo because most people, and it's not just people coming from Afghanistan, most people in the world, because of the social context, because of the stigma and taboo, they often hide their mental health problems or their substance use problems, and they avoid seeking help for these things from their families and from professionals. And so what can be really helpful is to not talk about mental health, but to talk about emotional well-being, to talk about how, of course, we expect people to be experiencing a lot of stress because of all of the things that they've been through, to have very strong emotions, to have a lot of maybe worries or sadness or fears, to have bad dreams or bad memories that they're trying to work through. And so what we can do is normalize those experiences, normalize seeking support for that emotional distress rather than pathologizing it. And we can provide psychoeducation, and we can connect people to social work, therapists, counselors, maybe not use terms like psychologists or psychiatrists, doctors for mental health, but instead normalize it. And that will allow people hopefully to seek treatment without having the stigma or taboo of the social context. And now I want to talk a little bit about the fourth part of the patient-centered approach, and that's really this negotiation. So when we get stories from people coming from Afghanistan about their health, it's often in the context of life events, and it's often related in a story form. In medicine, we're often taught to ask open-ended questions, but because of the time frame that we're working under, we often end up becoming quite focused in our questioning, and that can be seen as disrespectful by the patient. And so what we want to do is try to give space to listen to people and allow them to tell us what they need to tell us in a circular way if that's their communication style, in a story form if that's their communication style, but we want to give space for them to tell it as they want. And then as we listen to this story, we're going to then explain a little bit from the Western standpoint what we think might be going on, and we're going to acknowledge what those differences are before we make a recommendation for treatment. And in making that recommendation, it's really important that we understand, especially for our patients coming from Afghanistan, that there's often deference to power, deference to providers. And so assent might occur for the evaluation and treatment plan, but it doesn't mean that it was understood, or it doesn't mean that it was agreed to. It's just being polite. And so as we build trust, as we have all of these different cross-cultural communication skills, as we understand the social context and the meaning of illness, as we explore that with them, we're able to negotiate and really bring people into the treatment so that we're having a mutually understood and agreed upon plan. And that's always our goal. This listen, explain, acknowledge, recommend, and negotiate is called the LEARN method. And it's a really helpful tool in any patient encounter to really come to a space of providing culturally humble and culturally safe care. I'm going to give 4 examples now in the rest of our time, hopefully leaving a little time for questions about how understanding more about where our patients come from and applying this format of the patient-centered care and the LEARN model can help us to really provide high quality care with the cultural considerations in place. So the first example is screening for intestinal parasites. So when newly arrived refugees come, most of the time they're coming having had a pre-departure examination because they're coming through the refugee resettlement process. Our Afghan arrivals did not. They came very quickly out of country. They were resettled initially on bases here in the United States, and they didn't get any pre-departure treatment as would happen for typical refugees. So part of what we're doing at that first medical visit that we're going to talk about on the 28th of July is we collect stool cans to look for intestinal parasites. And when we're collecting those stool cans, we're asking people to go home, use a toilet, put this hat, we call it a hat, into the toilet, to defecate into the toilet, to take that stool, put it into a labeled can and return it. And this is not a pleasant experience for almost anyone, but when you're having to use a different style toilet and you don't read and you don't know how to know which stool can belongs to what family, you can see this is all even more complex. So understanding that people coming from Afghanistan have had different toilets, but in general, these are toilets where they would squat and they would defecate into the ground rather than sitting. It's really important to explain that how our toilet works. They're going to be sitting on a toilet, the hat's going to go into the toilet. And we've got to be really creative in how we label our cans so that we can make sure that we're treating everybody appropriately. Because of all of these different concerns and because of all these different challenges, we also need to make sure that we might want to not just treat the index case, because maybe the index case name doesn't match the index case stool, and there's some discussion there that's going to be really complicated. And we also want to know about how often people aren't using toilet paper. They might be using water. How are we going to use a glove? All of these different things. So these are all complications that are going to make it extra difficult and require us to understand the cultural context for all of this. Nutrition and diet, another space we often give a lot of counseling. And I think it's really important to consider the cultural context in which families are coming. So you can only imagine if you're used to going to the market and picking foods, you go to our grocery stores, I find them often overwhelming. There are an incredible number of choices of just peanut butter. There are huge numbers of choices, and you're trying to just navigate and find what you want in a grocery store. It can be very difficult. There's also not the familiar foods. And if you're practicing Muslim, you might not be able to find halal food, right? So it's helpful to be able to tell people that kosher foods are slaughtered in a similar way to halal food, or to direct people to neighborhood markets where they can get halal butchered lamb or chicken that might be familiar. We already talked a little bit about water, but the importance of letting people know that they don't need to boil water, that our tap water is treated and is considered safe. That can be really helpful so that they're not spending money on bottled water and they're putting money towards other things. And you can imagine what a conversation about bad food is, or junk food is like for someone who's been food insecure. So to label some food as being unhealthy food or bad food or junk food is really challenging when all food is good food because you haven't had enough food. So again, important to consider those cultural pieces when counseling families. Lead. This is a picture of a little girl who you'll notice has black rimming around her eyes. That is surma or kajal or kohl. This is some lead that's placed around, and the purpose of this lead is to prevent illness and to protect against evil eye. So this protects against any bad wishes or illnesses that might come to the child. And you'll see other children coming from other parts of the world will sometimes have black dots on the forehead to distract the evil eye away, or they will also have this kohl. The challenge for us is this kohl or surma often has high lead content overseas. And so when you do see this, you want to acknowledge that it's there for protection against illness. And remember, the majority of the world, there's very high mortality for children who are newborns or children under age 5. And so there are a lot of protections that people put in place for young children. So this is an important cultural consideration, but we just ask people to switch from using lead that they may have brought with them to lead that's from here so that we don't have to worry about high lead levels. There'll be a talk on lead in August, so you'll learn a little bit more about that then. And I wanted to talk about circumcision. So I learned from families about Aquikai, and I'm not saying that properly, which is a celebration of a child's birth that happens about the 7th day of life usually in Afghanistan. And a sheep is sacrificed, 1 for a girl and 2 for a boy. And at that celebration, that's when circumcision is traditionally done by the barber surgeon. And I love thinking about this because also, in addition to that circumcision that happens for male infants only, this is when a child's hair is shaved off. And so you will see this with lots of children. They'll have their hair shaved at a young age. And so the barber surgeon does both the circumcision for male infants and shaves the child's head. And this event is a celebration of the blessing of the birth of the newborn, and they invite families and friends to share the meat, and the meat is also shared with the poor. And so again, if a baby is born in the nursery, we do the circumcisions in the nursery. It's not something that's going to be able to be done at day 7 of life, but families can still perform all the other celebrations and the hair shaving at that time period. But it's lovely to acknowledge this, to acknowledge that this is a wonderful time. And if you're seeing somebody who's a newborn, who has a newborn and wants their newborn male infant to be circumcised, it's a lovely thing to know about, so you can talk about how we do the circumcision here as opposed to day 7. And when you say that, you're acknowledging the fact that it would be done differently in their country. So with that, I know we put a lot into the short period of time. There's going to be many more lectures that are hopefully going to expand upon all of this for you. And I hope you will continue to participate. But we just wanted to give a tiny bit of time to any questions.
Great, thank you, Andrea. And I think that was fascinating, and what important information to make sure that we're providing the best care to all of our patients and really honoring them from where they are and where they come from. So thank you so much for sharing that, both you and Tracy. So I don't see any questions in the chat box or the Q&A at this point. So if anybody has any questions, please let us know or type them in. And again, just to reiterate, we will be posting the recording as well as the full slide deck on the Vermont Medical Society's Refugee Health website. So you can go back, you can look at those. If you do have questions in the future, feel free to reach out to me and I can get a question to either Andrea or Tracy. So we are right on time and I don't see any questions coming in. So I will just say thank you to both Andrea and Tracy. And we will be back with another webinar on July 14th. And again, go to that website, check out all the webinars in the webinar series and sign up for the ones that you think would really benefit you as a practitioner and your patients. So thank you all. Bye-bye.